So thank you all so much for joining us this evening for the fourth in our Radiotherapy UK Talks series. My name is Sarah Quinlan, and I am the Director of Radiotherapy UK, the only charity in the country advocating specifically for this life-saving yet underfunded treatment. And we have our work cut out for us, as around 4 in 10 cancer patients are waiting too long for cancer treatment right now. We know that investment in radiotherapy can help cut these terrible waiting times, and it's one of our jobs to be out there and make sure that decision makers know it too. As we work on that, we continue to represent both radiotherapy professionals and patients, and I'll be sharing some short updates on our work at the end of Dr. Cozzi's presentation. I'm joined tonight by Lindsay and by Nathan, who will help run the session. Lindsay worked as a therapeutic radiographer for many years and will be helping out with the questions section later this evening. And Nathan is a student at Bristol University who has done some wonderful work interning with us in recent years. Tonight's guest speaker, as you know, is Dr. Cozzi. I'm delighted that Dr. Cozzi could join us tonight for his presentation, Adopting Adaptive Concepts, Workflows and Initial Experience of Advanced Cone Beam CT Technologies. Dr. Cozzi is a clinical research scientist with the Radiotherapy and Radiosurgery Department at Humanitas Research Hospital and Cancer Centre in Rossano, adjunct professor in medical physics at Humanitas University, also in Rossano, and clinical physics innovations director for the Medical Affairs Division of Varian Medical Systems International AG in Steinhausen, Switzerland. He has a fascinating talk for us tonight, and we will soon be getting started. But before I hand over to Dr. Cozzi, I'll run through some housekeeping. Just to note that as an independent charity, Radiotherapy UK are, of course, vendor neutral. We are delighted to be focusing on new developments and innovations in the field of radiotherapy, which is the focus of these workforce webinars. Please do use the chat function to introduce yourself. And for any comments or questions, this is a really good opportunity to engage with each other and with Dr. Cozzi. After Dr. Cozzi's presentation, we have time set aside for a Q&A session where we will get to as many questions as we can. Please do put your questions into the chat and we will gather throughout. We will also send a follow-up email following the webinar with a recording and any other relevant links discussed or highlighted throughout. So without any further delay, please welcome Dr. Cozzi from Varian.
Thank you and good evening, everyone. I will now start sharing my presentation. Okay, so I hope you can see my screen properly and hear me. So again, once more, thanks Radiotherapy UK for having invited me to this series of conversations. And as it was introduced, I am a medical physicist with about 30 years of clinical experience. And my main research activity is in the field of treatment planning, algorithms, and introduction in the clinic of novel technology. So this is my background. Here tonight, I will discuss with you some of the aspects of one form of online adaptive radiotherapy. And this special form is the one based on kilovoltage cone beam CT imaging as the key factor. I will go through some very basic definitions, and then I will have a quick tour with you through the current utilization and the evidence generation that is growing in the literature. As it was required, this talk is clearly as much as possible vendor neutral. There is a variant label in the back of the corner, but the contents are all based on scientific results through either congresses or scientific publications. So starting from the definition, so we can set the frame for the conversation. Adaptive therapy in general is a form of actions contained in a kind of closed loop where we aim to modify the treatment according to some measurements of the status of the patients during the course of the treatment and enabling a systematic feedback loop that allows us to put in place the measures that are needed to correct or to improve the treatment over each of the fractions of the radiotherapy series. So essentially, adaptive therapy means in the main meaning adapting the treatment plan that has to be delivered in a patient-specific and to cope with the changes that are unaccounted in the initial plan. This is something that has been established since many years, and it is a very valid definition. So what are the primary objectives of adaptive radiotherapy? Are the preservation of the plant validity through the course of the therapy. And two elements are the key factors: the coverage of the target and the sparing of the organs at risk. It's not necessarily that both are at risk, but clearly both are extremely relevant to guarantee the plant quality that we want to preserve over the course of the year. As a secondary objective, we might want to take advantage of some evolution and some dynamics during the course of treatment. The tumor response or the change of anatomy of the patient due to the therapy might suggest that some changes in the treatment plan can be implemented in order to further exploit the benefits of the dynamics that we can observe. All this is not possible with the standard approach where a single plan is treated identically through the entire course of the treatment. And eventually a first mitigation is has been introduced since many decades, probably a couple of decades at least, with the offline adaptive therapy. We all do it for head and neck, more or less at the third week of treatment, a new CT and the new contouring, etc. is done. But this is offline in the sense that we have to take actions while the patient is not in treatment on the couch, and we can spend some days in preparing. This is somehow the basics, the foundation, but we have now the opportunity to do everything online daily with the patient on the couch. So essentially, we need a plan that is the basics, the foundation. Then we need to adapt and to modify it according to the status of the patient every day. What is the central element that determines the feasibility and the possibility to this is imaging. And there are different options. You can perform adaptive radiotherapy online with MR-guided images or with kilovoltage convection images. We will focus tonight on this option, and I will have a first part to demonstrate that this is actually doable, and the quality of the images that we have today available with kilovoltage CT can enable a safe and high quality execution of the adaptive process. Just a little comment on the technology that is available in the clinics, and it is at the basis of the articles and the scientific evidence that I will describe with you. This has been implemented on ring machines with single beam energy, dual layer MLCs with 5 millimeter effective resolution. And it's, of course, a technique that is suitable and natively suitable for IMRT and VMAT. But the key point is that on these machines, the imaging has to be innovative, because this is, as I showed you before, the very key factor. So what are the hypotheses and the potential benefits of online adaptive therapy? Well, once we can guarantee the preservation of the plan, we could also look at some further steps. For example, dose escalation. If we can mitigate and reduce the toxicity to the organs, we might want to deliver more dose to the targets. We might want to accelerate further the treatments, so reduce the overall treatment time, not only per fraction, but also introducing more SBRT approaches. We can reduce the margins if we can really know daily where the target and the tumor is located. We don't need large margins to account for the unknown in the positioning of the patients, etc. And overall, everything contributes to the preservation of the plant quality and the possibility to improve the plant quality. One thing that has to be considered is that this is a multifactorial problem. There are plenty of parameters, free parameters that are in place and should be considered. And not all are necessarily directly correlated or linked to the technology aspects. For example, the frequency of adaptation daily or not every day, the margins used, and say that those prescriptions are not directly linked to the technology, but clearly are things that we can implement if we can use properly what is available in our clinics. So let's start from the very beginning. I showed you the logic flow. The imaging is the key factor. I mentioned that there are two options. We will discuss tonight about the kilovoltage imaging. And my now next few slides are aiming to demonstrate that the quality of the images we have today, in association with the clever usage of artificial intelligence in terms of automated segmentation processes, can guarantee that we can build and identify the anatomy of the patients every day while the patient is on the couch with the accuracy and the precision that we need. So let's start from literature and the data that has been published a few years ago by the pioneers in this line of research. The Washington University group investigated in very extensive way the new imaging techniques and devices compared to the standard devices that they had in their clinic. And you can see that the bottom line of images compared to the upper line of images shows a clear improvement in the quality, a reduction of the artifacts, and a definitely better contrast resolution and definition of the soft tissues, even if these are normal convexity images with the new detectors. So this is the starting point and the confidence that something was doable. But can we use these images for the real segmentation of the anatomy of the day? There is a very important study that has been published by the ICON group in Australia. It's a network of hospitals, and they are very active in online adaptive therapy, and they are, say, investigating several aspects. In this study, they simulated 12 patients and treated prospectively 6 patients, generating a total of about some more than 300, about 350 fractions that has been analyzed. And the study was based on prostate only. So it's a feasibility investigation for a very specific indication, but with the interprostate, with the nodes, and also with the prostate bed to be irradiated. So 3 different levels of complexity and different positioning and different usage of hydrogel, for example. So anatomy was changed depending on the patient. And the key questions, I will come several times through this paper, but the first key question was, can the AI tools available applied to the cone-beam images we have on this type of devices be sufficient to generate high quality segmentation that is usable in the clinics without the need of spending hours in fixing the problems of the images? And the results were positive. So this is another foundation investigation. For the main organs at risk, a very minimal number of patients or fractions required extensive re-editing of the contours, while the vast majority was either immediately acceptable or with minor edits, and the same for the CTVs. In this logic, the CTV is the key factor. The PTV is automatically regenerated out of the CTV. So the focus is on the CTV. Here you see that the blue line is dominating in the sense that for most of the fractions, even no edits at all were needed for the acceptance of the target volume of the day. So this is very important. Both the primary organs at risk and the target volumes can be identified, can be segmented automatically based on this type of images that I just showed you before. But the point is this sufficient, or can we make some step further? Technology is always, say, a little bit anticipating the clinical implementation, and people sometimes is forced to use technology because it is available. Here is a kind of vice versa. We know exactly what we need. We need excellent images every day to be able to segment without any doubt and any error the anatomy of the patient every day. So is there an innovation in the technology of imaging that can improve this? And the answer is yes. New detectors are being developed. Here, there is one specific detector that is at the basis of what I will discuss later. The key points are these are very large detectors with very high, say, efficiency and capacity, and the possibility to acquire images very quickly. In this specific case, a full set of images can be acquired in about 6 seconds, having a rotation. And this is important, having a ring machine, because we don't have limits in the velocity of rotation of the devices. 6 RPMs is pretty fast in radiotherapy language, and a full cone beam CT in 6 seconds might open some interesting avenues. So what is the status of imaging? The promise here is to have high quality images, Pound field unit accuracy. This is important for the second part of, or the last part of my conversation, and being fast. Low dose is in some sense a side effect, but it is also important for the daily imaging. We have to be very careful in how much dose we deliver to the patients. So this is a comparison between planning CTs on normal fan beam CTs, cone beam CTs of a normal LINAC, which we should be used to, and this next generation cone beam CT that I have just described a few seconds ago. You see that again, artifacts, contrast resolution, details are improved, further improved, and are at the very same qualitative level of the planning CTs. We can have a very detailed resolution. If you see here, the artifacts induced by the markers are almost totally eliminated. There is a very precise resolution of the boundaries of the organs. And this is very important in the abdomen and in the pelvis. This is a similar set of images for the lung in the thorax, where the cardiac parenchyma is very well resolved. Even if the heart continues to beat, you cannot eliminate all the artifacts, but you can see that the image quality is significantly improved compared to the normal CT. So these are further steps. And if you compare the contrast-based planning CT to this new model of cone beam CTs, the quality is extremely similar, and the confidence that you can generate all the contours you need in a very advanced manner is almost guaranteed by this type of images. Further step, what about the 6 seconds acquisition and motion management for the patients? This is a super important topic, and adaptive online therapy has to cope with online control of the motion of the internal organs of the patients. So there are several options. Conceptually, you can track, you can follow the motion and adapt during the motion, or you might have the idea to freeze and treat somehow. So if you are fast enough with the imaging and also with the delivery, and again, having a ring machine facilitate this topic, you can think about treating the patients in breath hold, any type of breath hold, deep inspiration of and exhale, whatever, depends on the anatomy indication, but this is conceptually doable. And this is a study that is done in Canada at the Nova Scotia Health Institute, where they are comparing the new type of cone beam CT that we are discussing right now with breath hold or in free breathing, against the old cone beam CTs or the fan beam CT for planning. And once more, you can see that there is a very direct equivalence and harmonization between the images of the planning and this new generation of cone beam CTs with breath hold. So this is again in the abdomen, and this is again in the thorax region. You can see that we can get rid of most of the artifacts due to the respiration, and the quality of the image as the contrast resolution that is similar or totally equivalent to the planning CT. So this is for the anatomy definition, and we can be very confident of that. The next question is, can these type of new images have also enhanced field unit accuracy and precision sufficient to enable planning, direct planning on these images? Because today there are some technical, workarounds to convert a cone beam CT in a kind of synthetic CT that can be used for planning. And this is not the future of adaptive therapy. It should be based on the images of the day, and also the calculation should be based on this. So if we compare for this patient along the dashed line, the planning CT and the cone beam CT in terms of Hounsfield units, you can see that there is a perfect match and extreme accurate pattern and reproduction of the Hounsfield units. There are many data in terms of noise, signal to noise, etc., but I want just to outline the high-level aspects of this new type of imaging that clearly enables the possibility to calculate the dose directly on these images. Longer detector, longer scans, and the possibility to calculate the dose. So the three elements: very good image quality, fast imaging, reduction of artifacts, and the possibility to calculate. So the basics, the pillar, the founding pillar, I hope it is demonstrated. So in the next about 7 minutes, I want to try to taste the pudding with you, because we have all the ingredients, but is the pudding tasting good, and is it sweet enough for the clinical application? So a couple of questions, or 3 questions. How frequently should we adapt? What could be the clinical benefit? These are the hypotheses. And can we afford not to adapt? Because this is a fully legitimate question. So starting from this image, this is the typical conference image where everything is automatically convincing. We cannot afford not to adapt. If we have a patient like this, and this happens, this is a real case, really treated in San Diego, in California, in the US, a cervix patient, which the CT, cone beam CT of the day, proved to have a target completely offset compared to the dose of the plan that was designed at the origin, while the rescheduled and re-optimized plan is covering the target proven. So this is self-explanatory. We should probably stop already here, but to have something more insight. And also looking at the conflictual or doubtful data that are existing in literature. Not every study is positive, and not every study is suggesting that we need adaptive therapy. This, for example, is very recent study that was performed on head and neck patients, and their conclusion was that it was not valuable, and there were no differences in the adaptive compared to the standard course of treatments. But if you look at the details, you can see that the margins were still pretty large, 5 millimeters. Now there are studies on head and neck and trials that are using 0 margins, or due to local ethical committee issues, 1 millimeter margin, which is essentially 0 margin. Maybe the study here that was a negative had very, enthusiastically extreme, endpoints with 25% reduction in xerostomia. Maybe it was unrealistic. And treatment with, this type of adaptive approach was not really tailored to the daily process. So maybe we have to be very careful, because the details matter, and we have to be very cautious when we analyze both positive and negative studies. But now, looking at the positive aspects, these are data published in silico, so still the first step, showing that if you do in head and neck adaptive therapy daily, you can have clear advantages in terms of the preservation of the organs at risk, some much more preserved than the others. When you compare the scheduled plan from the origin with the daily adapted plan, not in absolute, but in comparison between what you would do without adaptive and what you can do with adaptive. And for some organs, the advantage is simply huge. So again, another pillar convincing that it is needed. What is in the practice? Well, you can immediately go in the direction of reducing the margins. This is a trial ongoing in Copenhagen at Herlev University Hospital, and it's on bladder. And they started treating patients with standard IGRT margins. You see pretty large margins from 10 to 18 millimeters. Then they developed their own population-based margins from the early adaptive experience. You see a significant reduction in the values of the margins. And finally, they can adapt patients, or they can, apply margins adapted to the individual patient. And there is a further shrinkage. You see that when you apply this type of approach, you can have a volume reduction of about 45% for the PTV. And immediately it's obvious that all the organs at risk will be automatically super spared and very nicely protected. So this is an approach that is now routinely applied. It's in the trial that they are running, and it is the way many centers are doing. Back to the article from ICON in Australia, they measured the number of objectives, dose volume objectives, that they can improve if they apply adaptive compared to non-applying adaptive. The blue lines are for minimally acceptable, and the orange lines are for the ideal objectives. And you can see that the distribution is biased towards the positive. That means that many, 3 to 5 or also 7, 8 in some instances, those volume objectives can be systematically improved in a very large number of fractions. Remember, this is a very intensive study that they performed on about 350 fractions. So how frequently can we adapt? This study essentially demonstrated every fraction should be adapted. Is this exactly the reality or not? Now, the slide I'm going to show has been collected by the vendor through automated processes and demonstrate that in general, over the more than 100 systems that are installed, but these data are based on only 89 institutes, the frequency of the adaptation is not 100%, but it is in the range of this 90%, and that is super impressive. And depends on the indication, but it's a very stable data that most of the fractions are adapted. So I think I also provided you a quick dive through the evidence that we have, but is this sufficient? My answer is no. We need real solid and robust data. We need clinical trials. So what is going on is that this technology is provided by only one vendor, and so there are vendor-directed trials sponsored as it would be pharma trials, but there are also very large number of investigator-initiated trials, and these are probably more interesting. Both are anyhow aiming to demonstrate the safety, the toxicity profiles. Some of the studies are looking to local control, and many are investigating to very specific questions like margins, fractionations, exotic indications. So if you look here to the right side of the slide are the investigator-initiated trials. You see that there are plenty of different indications and plenty of different questions that can be asked. And what are these questions? What are the research directions? And what is the evidence that is under construction? Margin reductions, biological response, usage of multimodality imaging, dose escalation, and last point is the seamless workflow. This is pretty interesting, and I will spend the last couple of minutes on this. So this is the research which is ongoing, and it will take some time to generate the evidence, but the evidence will come. In the meantime, what are the low-hanging fruits? What can be done immediately? Two things. Expand significantly the usage of SBRT, because if you can really re-optimize the plan every day, even the few fractions are not scaring that much. You can be sure that every day we'll treat properly the plan as it is scheduled. And the other is the seamless. So very quickly, SBRT, again, the data collected automatically shows an increase of a factor at least 4 in the adoption of SBRT regimens in the patients when the adaptive schemes are applied compared to the normal IGRT processes. Same institutes, and the rationale is suggesting that SBRT is further enabled because you can image. But the final point is, can we do something very important for the workflow of the patients, maybe starting from palliative patients, but also very important for the health economics, for the logistics in the hospitals, and for globally the health systems. So the dream is to compactify the treatment, skipping some of the elements and being able to treat the patients within few days or even few hours from the announcement or the enrollment of the patient in the department. This is the very high-level objective, but is it doable? Well, since this is a talk for UK, this is an important contribution that came from the Queen's Hospital in Romford. It has been presented at Hestro already 2 Estros ago, where they aimed to use diagnostic CTs to generate a rough plan, and then at the day of treatment to re-optimize everything and to treat based on the cone-beam CT that was generated at the time. They applied this for very, very challenging, urgent patients, and they were able to reduce to 40-60 minutes their work. So this is very important, demonstrated in an, let's say, academic, but not out of the world institute. They have the burden of all the real world hospitals, and they have the need of solving this type of problems. So the last couple of slides are concerning a trial that has been published. So this is real evidence from the Free University and the Amsterdam UMC clinics in the Netherlands. It was aiming to the same palliative patients, reduce the time needed to prepare and to execute the treatment, and avoid completely the need of a planning CT. So they published on the Green Journal earlier this year, and they demonstrated that from consultation to treatment, they were able to execute in 2 hours, provided the patients had any CT, diagnostic CT, not older than 4 weeks. This was the only very specific requirements, a relatively recent diagnostic CT, and then everything was done at the machine with the online adaptive process. And this is a very special trial with 3 series of cone-beam CTs to verify all possible aspects and all possible sources of defects. But you can see that from the, say, physical telephone consultation with the patient or with the referring clinician to the end of the actions, so the treatment, single fraction, say 8 grays, for example, they were able to execute everything within 1 hour and a half, with some outliers a bit longer because the anatomy of the patient was complicated. But if you compare to the 335 minutes average time needed for the standard workflow, is a huge benefit. And again, it's important for the patients. These are palliative patients with pain. It's important for the health system, for the hospital. You can treat many more patients. You can have a much more efficient management of these challenging patients. Clearly, the starting point is with the palliative, but there are no limits. You can envision this approach also for more broader type of and categories of patients and try to fast and make simpler the entire process. I'm not saying that we will not need any more planning CTs, but maybe we will be able to use more and more diagnostic imaging, MR only, eventually. We can segment very nicely on MRs, and why having a planning CT if the new cone-beam CTs will be sufficient for the task. So in summary, adaptive online radiotherapy, not specifically with the KV based, but the data I showed you are only based on KV-CT, enabled, and there is evidence that we can accelerate and improve the usage of automation tools, for example, the AI for segmentation, automate the planning processes because the fast process is granted only if we have automated planning tools. So here the clinics forces the industry to develop very reliable and efficient tools. But we can also develop clinical scenarios. I showed you the SBRT or the seamless processes. We can therefore change radiotherapy workflow in very, say, significant ways and very important ways with clinical impact. There is space for multimodality, and I have not touched this, but this is something that is clearly becoming an evidence. The workflow can be very efficiently managed by the standard workforce that is available in a clinic. So depending on the nation are called differently, but the therapists that are normally operating a conventional machine can be educated and can be elevated to the level where they can evaluate the images, the plans, and execute the treatments under their main responsibility. There will be always cases where a clinician or a physicist will be needed, but it is already very clear from the data that are collected and from the experience in the centers that a new kind of evolution of the profession for the therapist is here, and this is enabling a very extensive usage of adaptive therapy. Otherwise, this would not be possible. Esther is working on this. There are positioning papers that has been published on the skills that are needed, on the training programs that are needed, but the future is already present, and this is a very important step that we take. Okay. So thanks for your attention. I think I used a little bit more than the 25 minutes. I apologize for this. I hope there is still time for questions.
That's great. Thank you so much, Dr. Cozzi. That was absolutely fascinating. And we'd have some comments and questions chat. So yeah, we have to go 5 or 10 minutes for questions. So I mean, I love the fact that you're saying, the future is here. It's quite often the message that we are giving within our discussions with the decision makers, that these technologies that can improve outcomes for patients are happening and available, and we need to look about how we implement them and how we, I suppose, ultimately make sure that patients are accessing the best, most timeliest care possible that improve our outcomes in the UK. So that's, I love that phrase, the future is here already. We might borrow that for some of our campaigning. But Lindsay, do you want to take over with some of the questions?
Yeah, I've got one here. In your experience, sort of in a clinical setting, what skill mix is required on set in most cases to kind of do the adaptive? Do you have like a sort of standard of skill mix?
In terms of, say, the professional skills, you mean?
Yeah.
In the typical, these are very new techniques, independently if it is MR based or KV based. So normally in the beginning, it's important to have very well defined protocols that are defined with clinicians, physicists for the, say, dosimetric aspects, and radiographers or therapists in order to be sure that they can monitor the relevant aspects. Second is that typically in the first phases of implementation, a clinician and a physicist are present at the machine. But nowadays, after few years, it's still very junior, but 2-3 years are now of clinical experience, it's more frequent that therapy can be executed almost entirely with this elevated therapist that requires some internal training, is not from day one, but it can be managed routinely with therapist only, and only when very challenging cases are present, for example, when the organs are not contoured properly or when the anatomy is so different that it is needed to have a clinician feedback, it is important to have them present. Being present is something that is also questionable in the sense that we have the technology. It's not yet used, but we might have the technology to have remote assessment of the patient data while the patient is on the couch and the clinician is in his own office. But at the moment, it's still the presence when there are challenges that is required.
Thank you. There's a question here. I have a question about further developing auto planning tools. Based on the literature, a lot of work proposes solutions to generate optimal plan, which sometimes is undeliverable by the treatment system. Do you think that this is a significant problem, or that even undeliverable plans can be adjusted to being deliverable?
Well, no, this is a super important problem, and clearly class solutions or patient or plans that you simply re-grab from a library are not the state of the art and not the future. What the solution should be, and in the data that I showed, is how it works. You have the conbeam or the image of the day that you segment, and then you rerun a full optimization of the plan using the clinical directives that were used for the original plan, but applied to the plan of the day. This can be automated because all the beam geometry is already defined, all the directives are defined. You have only to re-optimize on the new anatomy, but nothing else has to be changed. Using GPU technology, the time is super fast. An IMRT plan can today, with the hardware available, can be replanned, re-optimized in a minute. That's the order of magnitude. A VMAT plan is a bit longer because it is not purely fluence based, but it is in the range of, say, maybe 3 minutes, and you have a plan completely re-optimized. One element that is not covered by automated plan is if we have to verify before the treatment and do some QA. Being a physicist, I would say, yes, we should do QA, but online adaptive prevents this. Whatever is the technology, if you have the patient on the couch, you cannot do real QA. So the future here is to, or the current state is to do in silico QA using independent systems that can immediately after the plan is re-optimized using the log and the steering files of the machine, redo the calculation of the plan independently and verify if there is any suspicious effect. For example, you can also monitor the changes of the anatomy. If, let's assume, you have a protocol where the bladder has to be empty, and then you have a bladder that was not empty and it was really full. So the daily image will tell you that the volume of the bladder will exceed some thresholds or some action levels that has to be alarmed or alarming the people at the machine. These are type of QA processes that can be implemented. It's not on the delivery or not on the plan, but it is on the anatomy of the patient. And in my, I started treating IMRT in 2000, and I had only one case where the machine was failing. All other cases of QA problems were human-based, either the TPS or some mistakes done by the humans. These kind of things do not really require a measurement or can be automated with some clever AI tool that detects the changes or the outliers. And the outliers might be fully tolerable because the bladder might be full for some good reason. But if it is a real outlier that is getting out of the tolerances, out of the protocol, then we might even decide not to treat the patient and to make a new preparation of the patient. It depends. But automation has to go also in this direction, and it is going.
Thank you. There's another question here. What type of training do you think needs to be involved for the radiotherapy workforce to be up to date with these sorts of techniques? And do you think that's something that should be supported by industry?
Okay, starting from the second, yes and no. Industry shall clearly educate on the technical aspects. Every technology is complex and has its own features. So every vendor has to provide the technical instructions in very detailed, very good detail. Then I would say, and this is what we are doing routinely at the Humanitas Cancer Center, we are running clinical schools that are tailored to some specific technique, but are very clinical schools, where we educate groups of teams coming from different hospitals, normally a clinician, a physicist, and a therapist, or a dosimetrist, depending on the country, on the clinical usage, the meaning of the various, or the applicability of the various technical solutions, the workarounds, the protocols that you can implement, the expected outcome, benefits, challenges, etc. And this is something extremely important. The clinical education is a must. It's growing. In Europe, at least, there are several ongoing initiatives for clinical education. I'm not only speaking about the generic high-level courses from organizations like ESTRO. I'm really speaking about clinical trainings, peer-to-peer based, that, for example, we at Humanitas are routinely doing. We execute several schools per year, and this is a mandatory step. Industry is not sufficient because industry can teach the technology, but not the clinical meaning of the usage of the technology. And this can be only peer-to-peer.
I have one more question. I think we've got enough time, yeah? This is good. Will pre-treatment radiotherapy CT scanners become obsolete in the future?
I don't think so. I think we will use less and less. It will not be mandatory for every patient, but I'm not, maybe I'm too old, but a CT is still a CT. So for many patients, we will continue to use planning CTs and the normal workflow. We have also, and this is part of the evidence generation. I showed you the slide that there are, in this specific topic, 6 trials from the industry, and now we have about 20 trials from investigators. So it's about 30 trials, let's say, ongoing today on different indications. Maybe not all will demonstrate that adaptive is needed. So if we demonstrate that adaptive is not needed, the normal IGRT workflow will continue, and I'm sure that a CT will continue to exist. And last point, I'm not sure that all the machines in the future will be adaptive capable. I think for many, many years, we will continue to have normal Linux. And for normal Linux, the imaging might be normal. And so we will still need planning CTs. So I still see a future for declining, but still present.
Okay.
Okay. So I think that's the end of the Q&A. Thank you so much, Dr. Cozzi. It's been so great to get this opportunity to speak with you like this tonight. And we really, really appreciate you sharing your time and expertise with us and the workforce in the UK here. So thank you so much.
It was a real pleasure for me.
Thank you. Just before everybody heads off for the rest of their evening, I'd just like 5 minutes of your time. You'll also see in the chat that we're going to just ask for your one takeaway from tonight, and please do let us know, because that's really invaluable feedback for us to continue to develop this series and again run it again next year. So just to let you all know that we recently had a meeting with our Champions Network, which will soon be renamed the Ambassador Network, and we wanted to say that how privileged we feel to work with such an engaged and caring workforce. 805 of you responded to our flash workforce survey. And even though you're all so busy, that we so appreciate that level of response, which represents over 10% of the entire radiotherapy workforce. And right now we're working at pulling together the findings, and we will use those findings to reach as many decision makers as we can and hammer home these urgent calls for workforce engagement and workforce investment. So please do stay tuned to our socials to be part of this drive for change. We've recently been down to London filming with the Amethyst radiotherapy team around gamma knife treatment. We work closely with our patient engagement group to finalise this brief, and we hope to share this with you in the near future. and that it can become one of the many resources that you can share with your patients to support them through treatment. On that note, we were in Brussels last week speaking at the Economist Impacts World Cancer Series, and where we also learned about some great innovations and made some really good contacts. And with that in mind, we are currently working on a 10-year vision for radiotherapy, which we're going to launch at the start of next year. It's really crucial if we are actually going to improve outcomes for cancer patients, that radiotherapy is elevated and stops being a footnote or a bolt-on. It really needs and deserves its own plan, as does cancer, which unfortunately we don't have in the UK at the minute. And we have undertaken engagement with yourselves about this through our workforce survey. We're continuing with that engagement with patients, with other specialist groups, because what we want to achieve with this document is that it's practical, it's implementable, and that it represents what the radiotherapy community needs to deliver world-class radiotherapy. And if you're signed up to our daily newsletter, then you'll be the first to hear about it when it launches. And if you're not signed up to our daily newsletter, we'll send out in the follow-up email a link to how you can sign up to that too. And I'll just conclude with a reminder that we are back on October 19th at 8 p.m. with Ben Hard from Electa, who will be presenting on MRI-guided radiotherapy. And we hope to see you all there as well. So thank you so much for your time tonight. Thank you again, Dr. Cozzi. And good night, everyone. I hope you enjoy the rest of your evening. Thank you.
Thank you. Good night.
Thank you.